more with survivors of human trafficking and sex trafficking. So those can, get complicated when we are talking. So, yeah.
Okay, so welcome everyone. I turned the recording on. The reason why we record is for people that can't, they're working at this time, they can't hear it, and we later put that on our website so they can view the webinar later. But we're really pleased to welcome Shweta Kappor. Dr. Kapoor is an MD and a PhD who will be discussing Ibogaine and the promise of healing traumatic brain injury among special operation veterans. So Dr. Kapoor is a board certified psychiatrist and the founder of Calm Psychiatry in Scottsdale and Gilbert, Arizona. She's board certified diplomat of the American Board of Psychiatry and Neurology and a general adult psychiatrist. She's been trained in the research track residency at the UT Health Houston and earned a PhD in clinical health psychology from University of Alabama. She specializes in complex trauma, women's mental health, psycho-oncology, and chronic pain. She also serves as an adjunct assistant professor at Emory.
I'm sorry, I missed your call. I was driving.
Oh, sorry. Emory University School of Medicine, and is a research consultant to the Menninger Clinic. Previously, she was on the psychiatry faculty at Mayo Clinic in Arizona, and she's an active scholar and educator and has authored peer-reviewed studies on pain, suicidality, trauma, delivered invited lectures nationally, and served as an associate editor for the journal Pain. With that, welcome. And let me just ask you, one, do you have anything to share? And if so, I can give you access to share.
That would be great. Yeah, I just have my PowerPoint presentation.
Okay, that's great. So you have the ability to share. And two, what's your preference? Do you like to go through everything and then get questions, or do you want it interactive where people raise their hand during the talk?
We can be very interactive. I have like basic slides that I prepared, and but yeah, it's more, I would love if there's more of a discussion than just kind of slides, because I'm sure that some of you probably are familiar with it already. So yeah, questions in between or afterwards are completely fine.
Okay, it's all yours.
Okay, let me open it up. Wait. Let's see where my... Sorry, I'm trying to find that. It is open, so I'm not sure.
Okay.
Let me see if I can do it again. Come on. Oh, let me see if it is. Sure, it's not coming up. Oh, because okay. Let me. It's been some time since I presented. What am I doing wrong? I'm not sure.
Okay. If you hit the share, it's going to ask you whether to share a screen,
yes,
or a PowerPoint or a document. So if you want to share your screen, you can. If you want to share a particular presentation under documents, it should list it.
Okay, awesome. So give me 1 second. I think I have it. And what is that? Wait. Sorry, bear with me. I'm almost there.
No worries. Okay, we're starting to see something.
Okay, so
okay, we can see it.
Okay, awesome. Thank you. Okay, so hello everyone, and thank you so much for having me today, and thanks Laurie for the introduction. And so Ken and I have talked some about it, Ibogaine, and so I'm going to speak about that. And so I wanted to like bring in some of the clinical stuff, but then also like what our understanding is, like how it works on the brain, and particularly in context of veterans, especially the special operations, and why it can be like, it holds so much potential to treat PTSD, and as well as veterans who have PTSD with a traumatic brain injury. So that's what we'll be talking about if I can get it to move. Okay. So basically, just I will be talking some about Ibogaine and what it actually is, and that and then like what are the different stressors that what sets like special operation forces apart from other individuals. They can be veterans of the military or just like community, and then like how does like what exactly like, when we talk about PTSD and TBI in psychiatry, like what do we actually mean by it, and then just some information about like how is ibogaine really working on our bodies and our brains, and what effects there are, and what are some of the concerns as to why it's still not like very broadly used. So so basically, and I'll be honest, I hadn't like really looked at ibogaine as much as a psychedelic. As we all know, ibogaine is a type of a psychedelic, so it has a component that is very psychoactive. So that means that it produces a lot of like if someone consumes it, it produces a lot of different psychological effects, and that's why it's called psychoactive. As I was preparing for the presentation, I read much more about it. It comes from a plant. The plant is iboga, and it is indigenous to West Africa. And there is a specific religion, Buviti, that uses it a lot. They've actually used it for several centuries now. So it has been used traditionally for um, just having this psychoactive experience that they really believed was very healing for the body and mind. And then there were like a lot of like rituals that they still use it for. So, like I said, one of the main ones that they have been using it for past several centuries is the initiation rituals, or like what we call coming of age. So, young adults or older adolescents in in their um, community have to consume like large amounts of. So, how they use iboga plant is to get the impact of ibogaine is by consuming their roots. So they have to like the young adults and adolescents have to consume like high amount of the roots, and the psychoactive experiences that they have. They really believe that that sets them up to lead a better life, and so it's like spiritual awakening. They really believe that it connects you to the divine, and they have also treated depression, anxiety, like the sad, like they more often call it just sadness, or people not feeling as good by ibogaine. So it has been in human use for a very long time. So basically, like I said, they generally consume it with iboga root bark. They mix it with water. They make a powder. It's the same. It's kind of like very much similar to all the other psychedelics like MDMA, psilocybin. That it's like a waking dream, almost like a trance experience. And basically they talk about like this life review, very deep introspection about their life. And there is a huge part that culturally they believe that you also get in touch with the divine, but not just that, but with your ancestors as well. So it's like about wisdom, and they also do it in community, so it's a social cohesion. um, they believe that it really solves a lot of deep-seated conflicts like that you have internally. um, and I did not realize that they actually do a day of integration after that. So that is now being done very commonly for any kind of psychedelics, that you have to bring it all together. And that's why the psychedelic assisted psychotherapy is becoming very popular. So before we jump into, so that was like the basic about ibogaine, and as we go along, I'll discuss a little bit about how it really acts on the human body. But I just wanted to give like an overview. Most of you must be like pretty familiar with it. So PTSD, as DSM-5 are now describes it, there are like different criteria. It's A, B, C. So that I've just not divided them, but the basic thing that we look for clinically is you have intrusive memory. memories, hyperarousal, so like that irritability. It's like you're very hypervigilant. You will see if you work a lot with veterans, that they don't want to talk about like their war experiences. They don't want to talk, sometimes don't really avoid thinking about their combat experiences. And then the hyperarousal is also, you notice that in families that, let's say, your family member was deployed. When they come back from combat, they sometimes, like families say very commonly, that they just seem like a completely changed person. So they are very angry, they take offense easily, they're very reactive to situations. I've had veterans who really go far away on July 4th because of the fireworks. It's very hard for them because it, in a moment, takes you back and it's like a flashback. And so there's avoidance, there's a lot of physical reactivity, there is a lot of difficulty sleeping, and depression, anxiety. And if it is like really severe, then it can actually mimic psychosis and paranoia. So, so, uh, so TBI, right, traumatic brain injury, and its cognitive impact. So we see that a lot in our practice. Although TBI primarily in the beginning is treated by neurologists, but ultimately psychiatrists do a lot of management of TBI because there are a lot of cognitive impacts of it. And so there's a difficulty in memory, difficulty retaining things, and it actually overlaps a lot with the severe PTSD symptoms. So you have, a lot of times we get them and they really believe they have ADHD, which is actually coming from their traumatic brain injury, because it's very hard to pay attention. And there have been trials showing that low dose stimulants can be very helpful for TBI. And the problem is that if there's also a lot of trauma, then it can help with the memory attention part, but activate the trauma memories. So one of the things that I wanted to like just bring up is the prevalence of PTSD and traumatic brain injury overlap, like co-occurring, especially in war veterans, but also in special ops forces, right? So generally the community, and when they also look at like war veterans, it's the prevalence of PTSD is about 3%. Although there are a lot of this thing that might be underreported, but just as a contrast, in special ops, they see that it's about, so they're like, it really depends on the study, but it goes, so that's why the ranges are so broad. But they say it's about like 7 to 20%. And traumatic brain injuries in special op forces is actually really high, 55% to 85%. Is when you get really injured, hit on the head, and sometimes losing consciousness is a part of it, and but it's not always necessary. So special ops, because of the kind of work that they do, they are much more likely to sustain multiple TBIs during their, as part of their work. So what happens is that there is a lot of risk. So TBI in itself is um, it's a high risk factor for developing PTSD. So more TBIs we have seen, it's like worse psychological outcomes, so more cognitive impairment, and the the when it overlaps, then TBI and PTSD, it becomes like a vicious cycle. They both amplify each other and its negative outcomes. And so one of the biggest challenge in special op veterans is that when there is an overlap of PTSD and TBI, it takes some time to come to an accurate diagnosis and to figure out like effective treatments. So, so basically, the special ops, and I will talk about this and then bring in like how Ibogaine can be, is very promising and can be really helpful. So special ops, they have prolonged deployments, high risk missions, so they're more likely to be injured, and because they the missions are much more demanding, and they stay in deployments for a longer time. So of course that increases the risk of getting injured. I think this is also like inherent hypervigilance and that state of constant readiness to kind of like go on missions very, very quickly. And then one of the biggest things with trauma and TBI is, if you think about it, it's like layers of an onion. So it's a cumulative stress exposure. So it's like layers and layers. Once you start peeling them, that is when you really start understanding it. But like, think about like the less layers, it's not as complicated, but the more deployments, more missions, it just keeps increasing. So there is an accumulative sustained effect. Um, so basically, what I was talking about is long-term psychological impacts are PTSD, complex PTSD, depression, anxiety. There's a lot of substance use that it always plays a function. So for special ops, it can be to decrease the hypervigilance, to relax a little, to kind of like really take their attention away from all the traumatic memories. And so it plays a function in decreasing the emotional pain. There is a lot of impairment in psychosocial functioning, so damaged relationships. Um, I have worked with a lot of special ops veterans who are not in contact with their families or sometimes even children. So there's a lot of there can be profound depression, and then that of course like there's a lot of hopelessness, which can lead to like multiple attempts, suicidal attempts, or like having this chronic passive suicidality. Um, so basically, like diagnostic difficulties between PTSD and TBI is there's, like I said, there's a lot of symptom overlap. It's just like very hard to completely like distinguish it, which from psychiatry point of view, because they overlap so much and we treat them together, it's not as much of a this thing. But from neurology point of view and neuropsych, when they do it, it's very important for them to have this diagnostic clarification. And we don't have that many biomarkers or any for PTSD. I mean, they are developing it now, and VA is actually doing a lot of research in it. So we'll have some. I'm hopeful, but not right now. And there has to be like pretty intensive and extensive. So when we say like differentiating, that has to be pretty extensive, and sometimes that is not available all the time if you're deployed, and that can also make it harder. So the conventional treatments that we use are like psychotherapy, which um, I'm a therapist. Deep down, like I do a lot of med management, but I that's my core, and I think they are very, very successful. But that's very like prolonged, and the psychotherapy approaches that we generally use for a shorter time are the exposure therapies, and we're finding out more and more that they do help a lot, but they're still like it's not where we would like it to be. Then we use medication, rehab, and like I said, generally we have seen that the recovery can be not sustained, it can be incomplete, where you're still having a lot of symptoms. So that naturally takes us into like, how do we find treatments that are actually easily available, can be access can be easy, and then the administration and monitoring can be easy.
So,
So
Dr. Kapoor, we have a question by Dr. Schwartz. Dr. Schwartz, do you want to ask it or do you want me to read it?
You can read it.
Okay. Is pre-existing substance abuse a risk factor for TBI or PTSD?
that's a good question. I would a risk factor as in so here's how I would think about it. So individuals who have a prior substance use disorder, a lot of times we see that adolescents, young adults who have that, and they have a lot of trauma, and they generally go into military service very early on, and that definitely is a risk factor for post-traumatic stress. And that is like after deployments, because what happens is that they're already um, like I said, it's cumulative. So a lot of times we see that substance use at a younger age is associated with childhood trauma. And once they are through deployments, that really increases it. And that also, again, becomes like a risk factor for traumatic brain injuries. Um, it doesn't like put you at risk of getting injured. That is only if you're using it like actively during that time. But what it does, it really amplifies again like the symptom complex of TBI, with the cognitive attention difficulties becoming like more intense. So yes, substance use in the beginning can lead to um, like a more complex picture of trauma and
Okay.
TBI.
And Janina has a question.
Hi. Hi,
Hi.
Dr. Kapoor. This is a
Hey.
very interesting topic. So, I have a question regarding complex PTSD.
Sure.
There is an ongoing conversation in the arena regarding having complex PTSD as a
Mhm.
standalone diagnosis. So it's a two-part question. So, what do you um, uh, how do you define or distinguish between, regular PTSD and complex PTSD? And
Mhm.
second, how do you feel about introducing complex PTSD in the next DSM?
Okay, awesome. So you've asked me something that I'm really passionate about. So if I go on and on, stop me.
No, you can go on and on because
Okay.
this is one of my passions. So
Okay.
we're on the same page here.
Okay,
So
good. So your first question, right? How do we distinguish? So the way that we, Janina, distinguish is for me as a clinician, how I see it is that um so the basic difference, let me like backtrack. The basic difference is that when we describe PTSD, like when we say acute or chronic, that PTSD, according to DSM, is like it's a one seminal experience, like traumatic event that like then has a cascade of the PTSD symptoms, right? So
mhm,
they really, and this is more I've seen. Sometimes it can be that, let's say that a veteran has been deployed and they have this. I've had veterans injured by IEDs, lost a lot of their unit mates, right? And but they can like pinpoint that there is a seminal this thing. So if you just go by definitions and the symptoms, it's just then that is PTSD. That's one
mhm,
event where you felt that you were going to die, or it was you feared for your death, you experienced it or witnessed it, right?
mhm.
So the problem is that in real world, it's very it's not as common, it's not like so clean cut, right? That
Right,
right, you don't have to go to war to get traumatized, we don't like it happens here in our homes, right? Like children are getting traumatized, right? So
right.
the difference with complex is, I think, one, clinically it is more practical. It actually gives us a better whole like understanding of what's going on. So complex would be if a veteran comes, like he's seeing me, he tells he or she, they tell me that they went to army like very early on, like 16, 17, when the minimum age that they can go in. For me, as a psychiatrist, my first thought is that was their childhood trauma, and a lot of times there is. And then they go into deployment, and that goes back to Dr. Schwartz's question. Are they,
Mhm.
so they might have trauma, childhood trauma, substance use, and they go into deployment, they have TBIs and more trauma. So now when I see
Right,
them in clinic, they have all the symptoms of PTSD, but they also have a lot of like reactivity. They have a more intense
right.
impairment in their life. And when we're talking, it's again, it's like the onion piece, like there's layers and layers of trauma that have all
Mhm.
accumulated. And I think that actually applies to most of our patients,
Right.
civilian or military. So the second part is, should they include it? Absolutely, it should have been in
Oh,
DSM-5.
yay. Okay,
It's
good.
it's a huge disservice that we do. The problem is that when it is not recognized by American Psychiatric, they are not going to fund
Mhm.
it. So we're not like
Right.
really we're funding PTSD all over, but we
Mhm.
also, and complex comes in that, but we need like very focused complex
Mhm.
PTSD. It shouldn't even be a
Treatment.
disorder. It's such a normal human reaction to adversity.
Right, right.
And I hope they take off the disorder, and I hope that DSM 2026 it's coming out, they're working on it,
Mhm.
but WHO formally recognized it in 2023.
Perfect. And just one little question. In from your experience and dealing with this population, what percentage do you see experiencing psychosis?
That's a really good question, and I can look it up. I don't have a number.
It's okay.
Yeah,
Just
I'm thinking maybe less than 5 to 10%. It also really depends if you're working in safety net hospitals or you're working with um, depends like the demographic and depends on
mm,
how intense of a trauma we are seeing. So more complex, like if it's more complex trauma, like a lot of traumatization over lifetime, I think they present more with psychosis. But then it
mm,
also really depends of vulnerability, genetic vulnerability to serious mental illness. So
mm,
I think that also makes it, and that is why one of the other things that I really write about is teaching the residents and graduate students how to distinguish complex PTSD from psychosis, because
perfect.
it becomes like really, yeah, I
Yes.
that answer your questions.
Yes, yes, that answered the question. Thank you so
Yeah.
much. And thank you for your passion to bring awareness to this.
Yeah. Okay, yeah. Yeah, I'm DSM, I'm sure they hate me. I write about it so much. So
That's okay.
yeah,
We're gonna fight together. Thank you.
good. So again, like this slide is like just repetition of like the limitations that we have. So let's talk about Ibogaine then. And currently, Ibogaine in US is a Schedule 1 controlled substance by DEA. So that means that it's illegal to be for any of us to prescribe it. It's not available through pharmacies unless until it's a clinical trial. And so that is a completely different um, um, permissions that they have. So it got attention first in United States around like 1950s, 1960s. Then psychedelics were being used more in the community. And so ibogaine was in circulation a little bit, but not as much as mushrooms or MDMA. But then in around 1970s, when the use got more, 1970s, that's when they made it a Schedule 1. So illegal to be prescribed, and that has largely hindered research on ibogaine, as with other psychedelics. So it's also interesting. I think Ken, it was the first time when I was talking to you, it you brought it to my attention that special ops forces veterans actually there are clinics in Mexico, and I looked it up. I think there's some in Canada as well, that actually are administering ibogaine under pretty stringent medical supervision.
Yes.
And so a lot of special ops, because they are not finding relief with all of the conventional treatments we were talking about. So they are actually traveling to Mexico, Canada, and I know a lot of people travel to Netherlands for they call it trips, the psychedelic trips, and Netherlands. All of these places, this is legal. So Netherlands actually has this. You can go on Craigslist and actually look at it. You will find independent trip guides who can bring it to you in hotels. So that really scares me. But I think in Mexico and Canada, they're doing it under medical supervision, and they're particularly doing ibogaine.
I think that there are several different ones. I
Okay.
think because of the heart risk, right?
Mm-hmm. Mm-hmm.
Um, we've gone to several conferences and we've met with some experts. I think the people that are doing it really well, like
Mm-hmm.
there's a Dr. Fernando Rivas
Mm-hmm.
that he makes sure that everyone, it's more
Just
expensive,
magnesium. Yeah.
but they can't believe what patients say. So they say, yes, we're not on drugs, but they test them when they're on there. And if they
Mm-hmm.
aren't totally off, they have to wean them off. So they may have to be down there for weeks.
Mm-hmm.
Um, but with Dr. Fernando Rivas, he actually, and I have a presentation of his that's just excellent,
Mm-hmm.
but he staffs, he has like, it looks like a mini hospital with
Uh-huh.
really soothing lights, but you're hooked up to monitors and you have emergency docs and anesthesiologists that are the people that are there in case something goes wrong. The
Mm-hmm.
people that have had deaths are the ones that are going down for trips for people that say, I'm a healer. Well, if you're really a healer, you probably have more knowledge than someone that is
Mm-hmm.
a self claimed healer and may not
Mm-hmm.
have the medical experience.
Yeah.
But so there's a lot going on, but if you'd like, I'll put in the chat that I'm bringing back a movie that a friend of mine actually did. It's a documentary, and I filmed it. I had a screening here in Scottsdale. We
Oh, okay.
actually we showed it at the European Psychiatric Conference in Mexico City,
Uh-huh.
and a lot of psychiatrists were very, very interested in it. So they have the Stanford clinic there that treats all of these Navy SEALs,
Uh-huh.
and we've had some interesting discussions. But if you want to attend this, you do have to register. It's free. We'll have
Okay.
some
Oh, that's
things to
awesome.
eat and a few things. It's coming up November 13th. It'll be at the
Okay.
ASU Mix Center, which is
Oh, I think
across
Ken
from,
had shared that
yeah.
I
with
did.
me.
Yeah, I did,
Yeah,
Dr. Carr.
okay.
Yeah,
But
you can sign up if you can.
Okay,
if
I will
yeah,
definitely try.
but sign up early because we're going to give it to the vet ticks. And your
Okay.
other point that you talked about was something that we also talked about. Unless you're going to officer training, people
Uh-huh.
that go into the military often have come from families where they may not have been as healthy or functional, or they may have had trauma. So they go in early and
Yeah.
they create these, you know, war machines that are very good at reacting and killing, right? And then we don't deprogram them well. When they're
Absolutely.
done with their 8 tours or whatever, then we go, okay, have a good life, and then they go back and, like the film shows, they kind of blow up their lives,
It
and they go,
absolutely does, yeah.
yeah.
Uh,
So
I have
Yeah.
a quick question, if you don't mind. So, as we are very well aware, EMDR is the golden standard regarding therapeutic modalities. But for complex PTSD or for special ops, um, I feel that there's a hit, so to speak, in their identity and sense of purpose. So, what kind of therapeutic modalities do you think would be efficient? And then second, until we get the psychedelics up to par and approved and so forth, do you think that ketamine can be beneficial regarding acting on the amygdala? And then Lori, a request for you, if you don't mind emailing the link to the movie, that would be fantastic.
Yeah, that
So
would be great, Lori. I would be
yeah,
very
I
interested.
I put it in the chat since I'm not sure if
Okay.
so it's
okay,
in the chat right now.
okay, perfect. So
So, yeah, that's a good question. And EMDR is so I'm not EMDR trained, of course, and I think it can be really helpful. I think the problem with EMDR and complex trauma is EMDR really depends on a seminar, but at one time they take one event, right? And then they can go on to, and you can do it. I've seen some veterans who have really benefited from it. There can be, I think that one of the things that I really believe in is not as much as in trauma focused. I do that a lot with in my practice. It's trauma informed, which basically means that, when we get them, especially veterans or special ops, right? They come in and they went in a different this thing. They come home, they're so changed sometimes, right? And then it's like I have to be crazy, right? Like, this is not me. Like, what happened? And I'm going crazy. So a lot of them really believe that they are going crazy, that they are psychotic, right? So one of the beginning that what I do before they go on to more specialized, if they're doing like exposure therapies, which we are finding out more and more about the side effects, right? For me, it's very, I think it has been very, um, uh, kind of gratifying for me is to work with them to help them understand that they're not going crazy. This is a very, all this is very intense. It is how humans or animals respond to a lot of adversity, to fight, flight, freeze. And then it's helping them understand that what they think that symptom cluster is craziness. You just like take it together, like take it and help them understand that they're not going crazy. This is trauma reactivity, and really, yeah, and the role of the soma, so the body, somatic, this thing is that we think about like fire, like I had mentioned, the fireworks and these kinds of things as triggers. The problem is that with trauma, especially with such intense, complex trauma, your body is a trigger because it stores the trauma, and you have no idea, like nothing happened. You're sitting here and you're in a panic attack, and you like just feel that, okay, this is, I can't go on living my life like this, and this has to. So I think that trauma informed, like helping them understand what's going on with them,
Mm-hmm.
is the first step, and then it can be like medication, and like it can be together. But I think it's for most of the treatments, sometimes they don't work, is because they still don't have a good understanding. So psychoeducation, I think, is so important
Right.
that, yeah, like,
And somatic therapy would have a
I think it will
uh,
have a bigger and bigger role.
okay,
Yeah,
okay.
much bigger role. And yeah, and I think psychedelics will have a really big role. So,
Yeah, and with the ketamine, I was thinking like
oh,
the shrinking the amygdala because it tends to be in a hyper state with
mhm,
PTSD.
mhm.
If the ketamine can be utilized,
Ketamine, I think, will become big in PTSD. My only concern with ketamine right now, especially in Arizona, is it's some of the clinics are not really good. So, and it really depends because that's also a trip, and you need to be in a very safe this thing. So never ever do it without an anesthesiologist on board. It can really tank you, and so yeah, that's, I think ketamine is becoming really big. It's big for depression, and suicidality, and I think it just takes away the emotional pain, and I think it will become big in PTSD, but it needs to be done by people who are trained, because right now it's just like all over. So that's,
you're just amazing.
oh, thank you. Okay,
You're
thank you.
Doctor,
So, mhm.
Doctor, is this the end of your presentation or are there more slides? Because I'd like to hear more from you.
I just have things that I was going to talk about the Ibogaine. I have a couple. I think I really don't need to, if we don't have to like go over the neuro this thing, because that would be like very like a neurology part. But
No,
um,
I think we want to hear everything that you were prepared to show us. So,
oh, okay. Oh,
uh,
okay, awesome. But if you have questions, yeah, you can stop me. So I think so when I was looking it up, right, like it's controlled it's controlled substances, schedule 1. So there are advocacy like organizations now. So one is Americans for Ibogaine. So mostly special ops and veterans who are a part of it, and so, like therapists. But what they're doing is, it's their website is actually really good. I looked over it. They have tons of resources there about Ibogaine, and like what they are doing for Ibogaine, and for really promote, like wanting to bring it in more of the routine psychiatric this thing. So then we have Veterans Exploring Treatment Solution, vets, which I think have been very, very involved with the clinics in Mexico to fund them, and they do a very grassroots advocacy for it. So I think it's a nonprofit organization, but yeah, I think Laurie, the clinics, I don't know if they are the same ones, but they are funding clinics and research in Mexico. And what they are doing, these organizations, is basically going into state legislatures and really advocating for it. So I actually was not aware that these states now, and if you see, they're mostly like October's 2025, and then summer 2025, that Texas is putting in money for Ibogaine research, $50 million, and Arizona just passed it. So they are going to fund, the total fund is going to be $5 million. It's basically to study vets and psychedelics for
yeah.
PTSD TBI, but this specifically includes Ibogaine. And so the California one also passed in 2025. These are like coming from the legislature where they're setting money aside now. And so Greg Abbott has been a big champion of psychedelics now. And I trained there in the Texas Medical Center for my residency at University of Texas, and they have so much funding already for psychedelics. Michael DeBakey VA has a lot of clinical trials going on. So Indiana has expanded. They were doing psilocybin research, but now they just added ibogaine to it. So there are legislatures like coming along, bills coming along in Ohio. Washington has already funded, University of Washington, and then I just realized that they're doing a lot of advocacy in Mississippi these days. I think it's a senator or not, yeah, but the picture is the lawmaker from Mississippi, and so. So one is PTSD and TBI that we are more interested in veterans. The other part is the opioid use. So
Yeah.
ibogaine has been shown to be really good for opioid use disorder, almost like they're saying equivalent to methadone, and they don't have all of it, but the results that they are getting in the preliminary trials, they're very promising. So Mississippi, they want some of the money from the settlements to go towards ibogaine.
So
So
the people in the film tomorrow
uh-huh.
are actually shown in your little Senate right there. They have been
Oh,
the
they are.
ones. Yeah. So
Okay.
that tall guy in the gray suit and his wife in the black, that's Amber and Marcus Capone. And
Okay.
they're featured prominently in Waves and War. And they have been
Awesome.
going to all of these places and working with
Meeting with,
legislators,
yeah.
getting things passed.
Yeah, this is Greg Abbott and the one that they just did
Yeah.
a few days ago in Texas. So so there have been studies now. The problem with when we have it as a control one, that is like schedule one, it's very hard to get it even for clinical studies. So all of these advocacy, this thing, first and foremost, they're getting money for clinical trials. So there have been trials though already at Stanford recently, and they have published in Nature, which is like the gold standard. And they have shown that ibogaine has been very beneficial for treating TBI and PTSD, co-occurring PTSD in special ops military vets. And you all can read about it. They have shown like there is a reduction, about like 80% reduction in PTSD symptoms, and the executive function has really improved in special ops. And they also did a study in 2024. It's from the same group, but I'm not sure if you all are aware. So the the PI, the principal investigator for these studies, Dr. Nolan Williams, he actually passed away a few days ago. He was a young psychiatrist and at Stanford, and yeah, so he passed away, and there has been it's been very very sad. So I think there will be other collaborators who will probably, because he's very funded for these right now in California, but there is a full team in UCSF and Stanford that's working with him. So I'm sure that they will progress through this. Um, so this is more kind of like the neuro, like how does it like really function? So like I was saying, NMDA is going to become like really big for psychedelic receptors. They generally are psychedelics generally work on NMDA. So like and the results have been really encouraging with microdosing of mushrooms. And so I think ibogaine is going to be again like it's kind of like a shared mechanism how they work, and that is why they work on the opioid system. They have if so they are thinking that ibogaine will also become really big for opioid use. And then they of course like work on the serotonin systems. They influence the dopamine pathways, and so this is basically the main ones for mental health that the targets, and these are all like the psychedelics work on all of these. Laurie, were you going to say something?
No, I just sent you a note
Oh, okay.
in the chat.
Okay. Are we running out of time?
No, you're
Okay.
fine.
Okay. So what is it really? What are what is ibogaine really doing, and why do we think that in PTSD and TBI it's going to be really helpful for veterans? And basically, it really promotes neural plasticity. So all the neurons that have been damaged, especially in amygdala, which is the fear center, and then there are prefrontal cortex. We have hippocampus that stores the traumatic memories. All of these like come together. They are for post-traumatic disorder as well as TBI. So Ibogaine or the psychedelics that they really promote the plasticity. That means it promotes the growth of new neurons, making new networks, and that is like one of the they make more synapses. So that is how our brain functions very quickly. So it really promotes the cognitive part of it and the emotions part of it with the so the memories, the attention with hippocampus, with the emotions with amygdala. So they really facilitate neurogenesis. They also ibogaine also actually have repair mechanisms. So it helps like repair the ones that can be salvaged. So that is one of the ways that they do it. And again, it basically like what I was talking about. They work on ibogaine works on the trauma pathway, so limbic system, and then it works on the stress regulation, and it really works on the traumatic memories. One of the things about trauma and traumatic memories is when we see this a lot in court cases, like with sexual abuse or even war related crimes and things like that. When the person is relating or describing their memories, they are very patchy. And so the question comes up a lot, like if you don't even remember, how can you just say that there was a sexual assault? So the thing is that that is how trauma memories are stored, and that is why we can only pull them out that way. And psychedelics and ibogaine really can help us kind of integrate that. So that is also very helpful for PTSD. um, so yeah, it's just pretty much the same, this thing. So one of the things I think where ibogaine gets stuck, and I think Laurie, you were talking about that, ibogaine has been shown to have a really strong cardiovascular side effects. So what happens is they are very worried about arrhythmias and it tanking the heart rate. And so one of the things that the clinics in Mexico are doing is that they always like Laura, you mentioned the anesthesiologist, they it can tank the blood pressure now. And so it has effects on blood pressure and on the cardiovascular. So what they do is like they pretty much like hook them up to everything. And the study that they did at Stanford, they have them on the magnesium drip, so that is cardioprotective. So they have shown that actually the continuous cardiovascular monitoring, magnesium, and having very strong protocols can make it a very safe drug to use. So, yeah, so again, it's mainly like the neuroscience of ibogaine, very very similar to for psychedelics, so dopamine, serotonin, and it let me just so basically I think this is really important role that ibogaine plays in PTSD as well as TBI. It calms that state of hyperarousal with different working on different pathways, and it also calms down the memories, and so there is like less irritability. You're able to think better, the concentration becomes better, and your trauma responses become like more manageable. And so with all of this, uh, psychedelics and ibogaine like they're very good at doing that, and that is why they really work well with PTSD. um and then they when they were using it in the cultural, more like for centuries, they have really believed that it leads to emotional healing through the psychoactive experience. And that is why when we do it in clinical settings, having guides or psychedelic assisted psychotherapy is very very effective. Is because the ibogaine opens up like these pathways that can then be, they are more susceptible to kind of like processing it and making more sense. So most veterans who go through it like describe it as almost like universally it is described as a life-changing experience, and in a positive way. So So like, we talked about the repair mechanisms, and I think one of the things that we are talking more and more in MDA is the neuroinflammation, which is actually very much a part of PTSD, TBI, but it is very much a part of what we are seeing now with central sensitization, chronic pain, which is another very big area for special op veterans from the injuries. Um, Ibogaine actually addresses neuroinflammation in the brain. So there's not just one target. It can really, it has been shown, can promote emotional well-being as well as physical well-being for veterans. Again, it's like there is a lot of evidence now, especially from the clinics that are doing it, that it is very neuroprotective. So it actually has a sustained positive impact on the brain by like the neuroplasticity, the repair mechanisms. It's kind of like like giving you where there were none had been destroyed, the neural networks. It's basically generating more, and that has a very enduring protection. Like I've mentioned, that this was just kind of like people are using it for opioid use. So I think Ibogaine overall, especially after the publications from Stanford and UCSF, I think it's going to become really big. There are a lot of, and I didn't talk about that as much, but the cardiovascular side effects, and that is a big this thing, and why there are researchers in different universities that don't support it still. So that becomes more of a problem. And but I think now that the states are legislating it and are giving money for phase 1 trials, I think it's going to become big. I think one of the setbacks that psychedelics had was when the phase 3 trial results fell through for MDMA last year. And because of the side effects, and they pulled the funding, but now they are funding it again. So I think that was a big setback, that because of the side effects, and they were mostly, I think, cardiovascular again. MDMA came this close to be
Um,
approved after phase
I
3
think,
for
yeah,
PTSD.
I think the compass and the Lycos um, problem had more to do with some of the practitioners not following kind of ethical standards. They were crossing the line between what a patient and what a
Mm-hmm.
caretaker and a patient. So that kind of blew that. But I think getting studied again, and they wanted FDA approval. FDA doesn't really approve counseling; they approve
Mm-hmm.
drugs,
Yeah.
which
Yeah.
is another. The other interesting thing with Dr. Rivas's presentation, and he shows all the different psychedelics and
Mm-hmm.
their neuroplasticity half lifetime.
Mm-hmm.
And it's interesting to see all across all spectrum which ones have the longest half time in that teachable moment and
Mm-hmm.
recreating memories and detaching emotions.
Yeah.
That was good. But they also talked about, I think it was Chuck as an ER doc and some of the other ones, and we were at a conference, that they may even think long term this could be something they'd give for stroke patients when they're stroking
Yeah.
out, that they would
Mm-hmm.
do that and then help create the neuroplasticity before
Mm-hmm.
too much tissue dies. It was a very interesting and cutting edge of what once they be once they change the classification and allow research again, I think we'll learn a lot.
I agree. And because I am both a psychiatrist and a psychologist, I lean more like some towards psychotherapy. And I agree with you, Laurie. I think that was the you have to, so what they call as a study fidelity, like the protocol fidelity, is that like you absolutely follow that. The challenge, if you're doing like a psychotherapy assisted psychedelic assisted psychotherapy, like new programs are coming in, we don't have a standardized we don't have standards right now how we train clinicians for that. And I think we are still understanding, like it's an umbrella term, right? Psychoactive. So what actually happens for, so they the challenge, like if you think about it, the limitations are, we talking about the good trips, right? But there are bad trips as well. Um, a lot of my young adult patients will like when they do it in like rave parties, there are a lot of bad trips and people get scared, right? About that. So it has to be, I think the more we learn, we need more research. but we will only learn about it. And going back to what, Janina, you were asking me about complex, we can only study it if they are funding it, and for that we need we need this advocacy, we need a grassroots this thing, and we want we need lawmakers who are more open to these novel treatment, because it's still, I think, there is some stigma still associated with these being party drugs, like how we have known them for past several decades. Like, I don't know who I was talking to, and they were researching this, and they were like, do you want to know a trip with MD? And I was like, no, like, no, like, I can't, like, not right now. Although it seems like it's very cleansing, but it's still pretty scary,
Yeah.
like if it's
But I
going.
think too, I think, most of the time it's set and setting. The other big issues I think psychedelics have,
Mm-hmm,
and it's been a discussion at some of the conferences with
mm-hmm,
neuroscientists and psychiatrists and psychologists and others, is
uh-huh,
that it's very hard to run a clean trial when the
mm-hmm,
patients immediately know whether they've gotten the placebo or not. They try to use niacin, which will make
uh-huh,
you feel hot, but they
uh-huh.
still know these people over here seem happy. And I'm like, I just feel hot, so
Yeah.
I don't know how you get over that. And the other big issue that was brought up by a lot of people working on frameworks across the country for
Mm-hmm,
psychedelics is that the cost is really high to do it well. So for the clinics that have the emergency docs and anesthesiologists and have the equipment and make
mm-hmm,
sure people stay there, they're not in for the quick dollar. So if you say, I'm a former heroin addict and I've had trauma and I'm off it, and you get down there and you're still testing and have methadone, they'll keep you for 20 days.
yeah.
That's not, that is expensive. I mean, a typical course in Mexico, a lot of them, it's ten to $18,000.
Mm-hmm,
So the way that they get it funded now is through philanthropic funds that give money
uh-huh,
to vets. But
right.
will that ever be accessible? I think if you look at the true cost of debilitating
Mm-hmm.
PTSD or drug addiction or depression, it's far exceeds it with traditional medicine. But will they ever do that cost analysis to say, we'll pay for this? I don't know.
I think they'll ultimately have to do a cost analysis, like what it costs and what it costs to treat such complex trauma. And I think it will have to come together with the human cost of. I think at the root of it, if we think about it, this is all suffering, right? There is just so much suffering. And we also see that individuals who have, like, veterans, special ops who have PTSD, there are like PTSD, TBI, that also, like, accumulates, like, that is very costly to treat. And I think I think it'll have to be more, I think it'll take more time for it to become mainstream. I think that it's still seen as fringe, almost like we are still, like, learning to integrate it in our, like, day-to-day, like, conversations, and be okay with it. I cannot tell you, like, how many clinicians are like, and I mean, I see their point. They are wary of it, because I think what happened with ketamine, like with all the clinics just coming up, I think it becomes it's problematic. And I think yeah, it'll take more, but I think it'll need solid support. It'll need people like Dr. Williams and, like, the team who are working to kind of, like, really support them. And I think the main this thing would be the effectiveness studies. They'll have to go from almost like a lab, like pure this environment to, daily life. Because if you have PTSD, you just don't have PTSD, you have PTSD, you have very depressed, you have anxiety, you might have other, mental health, there might be medications on, I think so. But I think it's moving in the right direction in a way.
I think I think with what happened with Dr. Williams,
Mm-hmm,
it's a big setback because
mm-hmm,
it takes people that are in the space trying to move it forward. And
mm-hmm.
he was the doctor studying all this at Stanford,
Yeah.
and he was great. He flew out for my last showing, and he was
Oh.
talking to both both Marcus and Amber
Oh,
Capone, and I had other psychiatrists up there,
that
and
is
he was up
awesome.
there facilitating. But now here's a man that has spent his time trying to solve suffering, and then he takes his own life. So then
Yeah,
people step back and say, if that's what happened, and why couldn't that save him? So I think
mhm.
it's setting back the
It
whole
is.
discussion again.
There
Yeah.
have been a lot of grief with Dr. Williams because yeah, it
Wow.
was he worked on suicidality and yeah, he died by suicide. So
So Dr. Kapoor, it's so interesting that that this and Lori that this topic is we're discussing it today. So on LinkedIn, and I am connected with you, Dr. Kapoor. So I will send you a message too, because I would like to take this conversation further. I connected recently with the former Green Beret veteran, and there's what I notice is and I'm trying not to be judgmental here, but I will be a little bit in the psychology
mm,
arena. There's so much resistance regarding looking at the complex PTSD as a standalone diagnosis,
mhm.
so like I said, I'm supporting this advocate
Mhm.
that completed psychology degree, and
Mhm.
he's fighting to have this diagnosis recognized as very debilitating.
Yeah,
And
yeah, and I think it will be. I think DSM-6 will have to include it now that
mhm,
ICD-10 11 codes will have it, and because
mhm,
WHO and Europe is doing a lot of research on it, and I
right.
think most of the veterans are basically have complex trauma. And
Yes, yes. And it's interesting that Europe is a little bit ahead of the game. I was just reading just not too long ago about the European clozapine test. And I'm not gonna go on that soapbox, Laurie, I promise, with the clozapine. But that they're looking at the clozapine beyond the schizophrenia
Mhm.
spectrum disorders. And, so I think we might have to just listen to what the people across the oceans have to say.
Yeah, Europe is always ahead of us in
Right.
the novel psychiatric treatments. Yeah, so okay.
Oh, there was another question for you. Does it help with Alzheimer's disease? You would think with the neuroplasticity, maybe.
It will be. I think once they are recognized and we have more and more data to show because about like 15 years ago, we thought that the brain, there was no neuroplasticity. Like we said, like if your neurons are damaged, they're damaged for life. And then it started changing, right? And a lot of work in that, like in the trauma arena with neuroplasticity came from Harvard and Boston, like the group of Bessel van der Kolk, and they did a lot of work in it. But I think it will translate to a lot of neurological, disorders. Like I think it will be big for Alzheimer's, and I hope it is because those are like that is a suffering on a different level. Like it's just you just like are it's just like it wipes out everything, like your memories, and it's very. But I'm really hopeful that it will be used for dementia when they do that. I think it will at some point be used for because suicide is related very, very closely associated to emotional pain. So I did a lot of work on emotional pain, which uses all the same neural pathways as physical pain. So they did these studies that were published in Nature that showed that if you take an ibuprofen or I don't know which one and said they were using, it actually relieves your emotional pain as well. And that is very related to trauma, that is very related to grief, the emotional pain. And the one of the seminal factors in completed suicide is emotional pain, the
Mm.
psyche that we call. I
If
think
I
we
were
should
if I
use
were to guess, it probably is ibuprofen.
yeah.
That's amazing.
Mm-hmm. I think like yeah, I think the neuroplasticity that psychedelics are being shown to do, I think they will be
Mm.
employed in so many other things.
Yeah.
Wow.
I think I'm trying to remember, Chuck, what's the name of the lady, Gretchen, who's from Something Mind, and they're recruiting right now across states for LSD studies
Hmm.
for for depression, anxiety, and such. So I had dinner with them. We did a couple weeks ago, and I said, "So are you guys microdosing?" And they said,
Uh-huh.
"Oh no, this is full on dosing." And it's I'm trying to remember how they're
Mm.
trying to
Is it like
gather
MindMed? Gretchen Shaw?
my yes.
Mm-hmm.
Oh, wow.
Yeah, they're doing phase 2, phase 3 clinical
Yeah,
trials right now.
yes.
Yeah, that's
And
for generalized
yeah,
anxiety. That's
yeah.
awesome.
And they're doing also Dr. Sisley is doing psilocybin
Uh-huh.
trials right now
Okay.
in North Phoenix for
Um,
I'm trying to think who she's asking psychiatrists to recommend people with I think severe anxiety and maybe
Okay.
depression,
And
but she's doing her trials as well, and she's getting first responder fighter fighters. Who else? There were vets. She had categories that she was
Uh-huh.
recruiting
um,
with.
So the first responders are going to be like a big um um
mhm,
set of like a population that would really I think
mhm,
will ultimately also help with the immunotherapy related brain damage and like a lot of the cancer treatments and
mhm,
because I think they will play a bigger role in all of these disorders. It just depends like what the how much they are putting in like the funding and
mhm.
everything and to have more people kind of like come up for these
Yeah.
studies like
I
volunteer.
think I
Yeah.
think they're trying to run a bill. I don't know if it's going to run this year, and
Uh-huh.
it's the right to try. I think it's a federal law,
Wow.
but
Oh,
they want
okay.
to do a right to try for people that are dying or kind of allowing them to do like psilocybin. What they
Mhm,
found with people doing it, then they're less scared. They kind of
mhm,
give up their pain. They're not afraid of death. Um,
mhm,
it's just kind of a kinder. So I think we'll see
mhm,
more legislation trying to ask for that
mhm.
approval.
I would be really curious.
I think that already exists, Lori, on the federal level. And what
Yeah,
you're talking about is that any patient has the right to uh,
try.
ask a given pharmaceutical company to let it use whatever products they have on their case.
Mm,
And that already exists in federal legislation. I'm not
mhm,
sure if you're talking about maybe we need to run that bill on the state level as well.
I think Sue is trying to get it so people have a right to try psilocybin and psychedelics because no one has that on their formulary. The other thing is, I think one of the Compass or one of them got some legislation passed, but they only want their molecule covered. And
mm,
Oh,
people are upset about that because people that don't know enough supported it. And what that means is they'll get their very expensive, slightly modified drug,
mm.
and then no
oh,
one else with all the other um,
Huh.
the non
Yeah.
copyrighted one or whatever,
So
the
so that
generic
that
ones won't be
yeah.
covered.
So
Yeah.
that's basically like a monopoly or monopolize the market. You know what I was wondering, Dr. Kapoor, if like um, before and after brain
mhm.
scans were done to see if how the activity.
I think they did the Stanford studies. I think they did EEGs.
Yes.
And I think they did MRIs.
Mhm.
So they were
Okay.
showing the thickness of can
It's
we
a functional MRI.
yeah, functional
Right.
MRI, yeah.
Functional
Right.
MRI means you're deriving data
Mhm.
secondarily to the way blood circulation shifts
Right. 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 Right.
under different stimuli.
Yeah.
Right.
Yeah, so all of these things you're talking about are not primary. They're not primary observations. They're all being derived from secondary research. Insofar as these things like neuroplasticity and the
Mhm.
growth of neurons, there's nobody in there with a microscope looking at
Yeah.
neurons
But
growing.
Mm-hmm.
yeah.
Right.
Though I don't know that perhaps cadaver studies might show some change in anatomy, after it
Yeah.
on a microscopic level, where you could actually look at
It-
slides of brain tissue and see whether there's
and see if there's actually like pruning and all that.
exactly. So it's very interesting stuff. I
It
must
is
say.
fascinating.
I think it holds a lot of promise, like the psychedelics. I can
Wow.
like think about so many other things. It's like basically about traumatic memories and a lot of,
Hmm.
I think at some point, like even like people who have first break psychosis and, like I think a lot of times I think we should be able to use this more broadly, but I think that is like it'll take a long time. But I think if they can get this too, so they're focusing on PTSD, TBI, and depression. If you think about ketamine and
Hmm.
more like they're doing more, I mean, like the cannabis, if you think about like if you're like thinking about the what we call drugs or substances, is the cannabis is being used a lot for anxiety now, and
Hmm.
all the chronic pain ones have not panned out. Like they haven't, like the clinical trials have not been able to
Hmm.
show clinical
Yeah.
efficacy. But most of the veterans that I've worked with have I mean they report like a lot of benefit to chronic pain with like
Hmm.
the gummies.
Yeah.
Nothing
Well,
touches them, and but I'm thinking like more in terms of like the opioid use disorder that um has like really ravished communities. I think
Right.
psychedelics will become big. I did not realize before I was preparing this, that Ibogaine is also being really promote, like they think that it will be able to be a very viable treatment for OUD. So I think that would be like really big with the
OUD.
opioid use disorder. Yeah.
Oh, opioid. Okay.
Mm-hmm.
Got
you
it.
know, so Chuck, at our some of the conferences in New York and either Colorado, they talked a lot about, and you know a lot more of the history of the psychedelics and research, how they were really effective in alcoholism and drug
Mm-hmm.
addiction back
Mm-hmm.
Mm-hmm.
then, and they showed a lot of promise until it got kind of swept up into the anti-war movement and right.
Well, the underlying, you mentioned this in passing, but it's actually the biggest problem we have with this class of drugs. You mentioned there's a stigma
Mm-hmm.
attached to them, but you can't just mention that in passing, because that's the foundational basis of the
Mm-hmm.
pushback against
Mm-hmm.
using psychedelic medicine. Uh,
Mm-hmm.
psychedelic
Sure.
medicine. The
Mm-hmm.
underlying problem, in one word, is that, well, three words, is they're too much fun. Okay, and that's the problem. Okay,
Mm-hmm.
so whenever you want to start doing research in anything that has to do with psychedelics, that memory comes back to haunt the entire enterprise.
Yeah.
That's why we have so much trouble
Mm.
getting these drugs into play.
Mm-hmm.
It's an interesting.
Huh.
I'll tell you something that doesn't make too much sense to me, but it's an entirely different thing. I'm just going to go off on a little tangent here. There
Mm-hmm.
is for for treatment-resistant schizophrenia, there
Mm-hmm.
really is only one drug that works, and that's clozapine.
That's been, yeah.
Mm-hmm.
This drug, similarly, is having a hard time pushing into where the domain where it should be used
Mm-hmm.
so much more,
Oh,
Mm-hmm.
yes.
not because it's too much fun. It's not any fun at all, as a matter of fact.
It's not like the
It's an
same.
entirely different reason, but the
Mm-hmm.
pushback against using a very useful drug uh,
Right.
is similar. I see the correlation.
Yeah, and that's basically based on a skewed on a study that the results were honestly skewed, and everybody freaked out about the granulocytosis and all that stuff, and now people are scared to death. So.
Yeah.
They have the one thing that they have done for clozapine right now is that they have taken away the REMS, so you don't have to register. And I mean that
But that
just happened, right?
But that's
Yes.
good and bad. Now, clinicians, because we've gone and talked to psychiatrists, they're like, well, how, again, it's a very real issue when you first start that you do need to monitor. Now that you've taken
Mhm.
away the framework, some of them don't know what to do. So I think in London, they're coming up with a framework. Hopefully in the US,
Mhm.
they'll do the same thing.
Mhm.
Well,
Dr. Schwartz has her hand up.
Yeah, I had a question for you, Dr. Kapoor. How did you get interested in this particular branch of the field in the first place?
Which one, Dr. Schwartz?
The special
Psychedelic.
ops and PTSD, TBI.
Oh, so I think um to be fair, I would describe myself as a very so it's the different populations, right? Like with trauma, I think my core is complex trauma, and I'm very interested. So special ops is I got very interested in it as a population because I do all populations. I'm very interested in I do a lot of childhood sexual abuse, I do a lot of workplace harassment and
Mhm.
more sex trafficking. But the special ops was when I was working at during a PGY4, I rotated through Houston Methodist. So they actually are funded. I think it's like at that time they received their first grant of 500,000 from what was DOD at that time, and that was all. So they have this whole program at Houston Methodist in the under the Department of Psychiatry that only treats special ops. And what they have done is they have brought together multidisciplinary teams. So there are psychiatrists, psychiatry residents, we have psychologists, and we have art therapists and with work rehab. And they basically
Mhm.
what they did was they took the meningeal clinic framework from almost like how it has been since World War II, and they replicated that on an outpatient this thing like an IOP at Methodist, and they got funded
Hmm.
only for special ops. So they're still publishing a lot with them, and that's when I got that was probably my first introduction because I did not have an idea about like the difference between military veterans and special ops, which when they were in the process of they had just got received that grant when I rotated with them for 2 months. So that was a big area of discussion all around.
Mhm.
And I think they have since published, and that was 2020, and I think they have since published and they are showing really good results. So that's kind of
Mhm.
like was my first introduction. And then just because trauma is my core, any population that you talk about, I'm always very interested to see what the similarities are and what the
Mhm.
differences are. So because I in my residency, the last rotation was like Bentop, which is like safety net hospital for Houston during COVID, and I went to Menninger Clinic, which is a very high SES, out of pocket.
Wow.
And what threw me was I thought that when like I don't know, maybe I equated money with not having trauma, and I was a young adults attending, that's my area. And there was just so much relational trauma. There was just so much.
Yeah. Wow.
It was so sad. But yeah, I don't know if that answers your question that I
Well,
well.
I just got interested by this topic. I mean, I'm interested in PTSD and regardless, but the information that you brought today is like wow. Um, and actually, I would like to look into the Menninger
Oh yeah,
clinic.
it's
Yeah.
I love it. I wouldn't have left it if my husband hadn't decided to. I mean, he keeps moving and I keep following him. So,
Well,
but I like Arizona, so,
Yeah.
so it's been all
So,
good.
so Francis, you have a question?
Yeah, so I was going to ask Dr. Kapoor, is this that company, the HD Research in Houston?
No, which one is that? Is that
Oh,
Houston?
HD Research that's in Houston. That has
Oh,
all the things you were talking about.
huh. I didn't
Oh,
know. Maybe it's a part of, yeah, it is in Houston. So maybe they are doing, no, I was talking about Houston Methodist. It's one of the thing, but
mhm.
um,
Yeah.
but this is also a Houston company. Yeah.
Yeah.
Hmm.
I had just went to a NAMI conference in Austin and
Okay.
talked to them. That's why.
Oh,
Hmm.
I really miss Houston. I miss the thunderstorms and the rain. I
Yeah.
love them. And when it rains here, everybody's like going. I was like, yeah, in Harvey, it rained like in our area, it was 6 feet in 6 days. So
Wow.
when I was
Wow.
like, yeah, this is so little rain. So that's my only complaint with Arizona. We need more rain. So
I
That's
agree.
true.
mhm.
Wow.
any last comments or questions for Dr. Kapoor? I mean, it's a really new subject. I did send you the Ibogaine presentation for
Oh,
Dr. Rivas.
oh,
If
thank you.
it's left my email, you'll see it. And everyone, if
Okay.
you want to see the film, I put the
See
sign
it.
up
Yeah.
Mhm.
in there to
Yep.
just sign up for it. And we'll have the new ASU dean. She's a psychiatrist also. So she is going to facilitate
Awesome.
the panel instead of me. So it's being really upscaled. We'll have I have to you'll see in there who we have as speakers. Now I was going to bring back Amber and Marcus Capone, but they moved to Texas and they have a vets gala that they want to meet and Chuck to go to. And I said, we can't. That's when we're hosting the event. But they're going to record what their impetus was to look into this. This was a last ditch effort to save their family and their lives, and it did. And they are committed to helping other veterans do this. And it's all philanthropic money sending people out of the country until we can get it decriminalized for medical use only. No one wants it for recreational use. That's the other fight in the community. Some people want it decriminalized for all, and we're like, that's a bad idea.
Yeah, that's about, yeah. You might Laurie might look up Avril Lavigne. I think that's how she
Yeah.
pronounces it. She was at Michael DeBakey. Is very heavily funded for psychedelics, and she's a psychologist. But I'm not sure like how. I mean, you'll see one of the medical ecosystem in Houston. They keep rotating between UT, Baylor, Menninger, and Methodist and VA. So she went from VA to Menninger now, and so I'm thinking she took her funding, but she's also really big in this. She's very heavily funded, and she does a lot of talks. And yeah, I think she came to them from Baylor with VA, then she went to Menninger. So they all keep like rotating through those hospitals. Yeah.
But I do think that Gretchen, if you're working with Gretchen, she's been in the field as a
Mhm.
political consultant for years, and she does a really good job of trying to get people to think through not only the clinical application, but the legal and decriminalization
Mhm.
aspect, and then what frameworks we need to make sure this isn't a train wreck where, you know, where young youth are going to get hold of these um, medicines. I mean, no one wants that. We want ethical use and for really medical issues. But interestingly, when you go to some of these conferences, you have people from other countries that have indigenous practices that say, "Oh, we give this to our troubled teenagers. Here, you need to do this," and they surround. But that's part of their. That's how they live, and it helps them figure out what they need to figure out.
Mhm.
But it's a whole different way of living.
It is, cannabis is one of our Hindu main gods, like Lord Shiva. He's been shown to use it, so they do it on Holi. I mean, I've never tasted it, but it's like in the rural parts. That's supposed to give you this like connection with the divine, like they describe it like that. So there's not that much stigma actually associated with it. It's also, I was just thinking, Laurie, I think a lot of them who do this work, like if there's any, like if they ever want to talk to me to get a perspective from the trauma aspect, not just the substances, but like what it does for trauma and neuroplasticity, because that's kind of like my area is
Yeah.
because the advocacy can be for, like the trauma survivors, like advocating for women who have been like brutalized in homes, men who have been brutalized at home, and then they go in for military. And so I think like understanding like what it really does for PTSD and how it changes lives, and why we should be funding it more
Yeah.
to, of
I
course,
do
like
want
bring it
to.
more
Yeah, I
ethical.
do want to find some of I think I have to go back into the portals to get some slides, but I did take a lot of pictures of the neuroplasticity of all the drugs.
Mm-hmm.
The other thing is, how do you feel though about cannabis-induced psychosis and kids that are doing it when their minds really aren't formed well, and then pathway to psychosis or schizophrenia. I mean, there is a danger to some of these.
It is. So we don't actually, so the because when it was coming up a lot, when it was getting legalized and everything, so I was still a resident in Houston, so we saw a lot of it- so I was at Harris County Psychiatric, and it was we would have like all these young people coming in who would have they would say they have used cannabis, they're like floridly paranoid. So paranoia is one of the hallmarks of a cannabis if we think about psychosis. The thought there at that time was that they had Kush, which is like a synthetic, cannabinoid, which was mixed with this, but we have more research now that it shows that in young brains, it can actually induce a psychosis that doesn't go away. Like we would put people on antipsychotics, 3 days, they would be like golden, and we would just like discharge them without any medication. They would come back in like 2 3 months, the
Mm.
same thing was repeating, but then we saw a few that the psychosis never resolved. And so I would say that people often have used, even in our friend circle, they call it a soft drug. If I keep telling people that for teenagers or for us, there's no soft drug, like that doesn't have any
Mhm.
meaning, like don't use it. Like that's what I say.
Right.
Like why do you want
And
to like test this hypothesis that whether it can be psychotic. You don't want to be like psychotic for life. So I would just say
right.
it should be a big no.
And Dr. Kapoor, do you think that the potency of the cannabis these days has a lot to do with? I mean, I think that manufacturers have to tone it down regarding the potency because I think that definitely is.
It's like when we talk about cannabis, like what people don't realize, like with the weed and everything that they call, it has more than 90 psychoactive substances, and some of them are natural, some of them are, and a lot of times the potency really depends on the how much like percentage of these are present. The
Mhm.
problem with when you're buying it, like I often tell my younger adolescent patients that don't buy it from they say no, we trust this drug dealer. I was like, okay, but
Mhm.
how do you know that
Yeah.
drug dealer is getting it from the same person? Like even adults tell me that it's our this thing, and I was like, no, oh my God, like don't use it, like use it.
So, if you think about it in the 70s and whatever, when the hippie era was going on and all that,
Mhm.
I mean, I don't think that it was such an epidemic of cannabis
Mm-mm.
induced psychosis. So I think definitely the way the manufacturer are manufacturing and synthesizing and all that.
These are like
Uh,
cannabis still largely for young adults is a street drug, and
right.
they buy it, right? And then I think what happened with the hippie movement was that psychedelics got on the six schedule ones, and that
Yeah.
halted the research, which I
Yeah. I
yeah,
hear
I
you.
mean, again, it's that, what Chuck you were saying. It's like that's stigma kept building up, and now it's like you can like they tell me, like some of my patients, that they're going to do it at a rave party because they felt so much better, like from childhood
Mhm.
abuse. And we keep telling them, like, don't do it, like don't do it, like
Right.
no psychiatrist ever says that you should do this, but for drugs, we're all like the street ones that they get. It's like, nope, don't do that.
Right.
So yeah.
Wow.
Okay, I need to run. I have a
Okay,
patient
I
at
know.
5:30. Yeah.
Thank you.
Thank
Yeah,
you.
Thank you
thanks
very
for
much.
having me. I
Thank you
really
so much.
enjoyed
You're
this
amazing. Thank
conversation.
Thank
you.
you.
Yeah.
Thank you very much, Doctor.